All right, everyone, welcome. My name is Dr. Cassie Jacobs. I am a full-time faculty member here at the School of Social Work at VCU, and I am really excited for our conversation today, which is about crisis work and serious mental illness. We have Emma Greenburg with us today. Emma is going to talk to us about this. Emma has been working at RBHA Crest for 4 years now. Emma came to us highly recommended by some other crisis workers as someone who has the knowledge of an expert but doesn't talk or speak down like an expert, which I think is a pretty incredible compliment to receive. So I'm really excited to hear about what Emma has to say. Emma has said that they are happy to take questions as they go along, but remember you can put them in the chat and use your raise hand feature. We will be putting the attendance sheet in the chat. So in order to get credit for today for that digital badge, please make sure you're filling that out. And I'm going to turn it over to Emma. So thank you very much.
Hi, thank you. My name's Emma. I use she, her pronouns, and I'm going to be talking to y'all today about crisis work and serious mental illness. So just to start off, I have seen some folks in the past give some introductions on their own history. I wanted to provide the same. So did my undergraduate work at the University of Mary Washington studying psychology. I thought that I wanted to become a school social worker. So I applied and began my MSW at VCU School of Social Work and was doing the School of Social Work track. So while attending grad school, I worked part-time with an organization assisting survivors of domestic violence. And I learned a lot about systems and programs within the greater Richmond area, which was so important as I was new to the city at that time. So while doing field placements at VCU, I really loved working with youth in elementary schools, and I gave high school age folks a try during my second field placement. And I was noticing how so much of the work that I was doing there was so attendance focused. I felt like we were missing the bigger picture in that work. Students were not attending school for so many reasons, lacking support and community at school, but also because of their home life. Maybe it was their mom who was a single parent and had younger siblings that were sick, so that student had to stay home to watch them. Or maybe transportation in the family was broken and there were no other options. Often what also was happening was they were witnessing violence in their neighborhood and community, and their family didn't feel safe sending them back to school. And it just felt like we were missing the bigger picture, to be talking to people about the importance of attending school simply for adherence rather than recognizing all of the things in their life that were going on and addressing those appropriately. And so I decided to change my plan at that time from school social work and finished my clinical concentration. Graduated in May of 2020 at the height of COVID, when so many jobs weren't sure whether they were hiring anyone at all, as everyone was just trying to figure out what it looked like to have their roles be virtual, factoring in all of those pandemic restrictions. So I started working at RBHA during the summer after graduating in 2020. And I've been at RBHA ever since. So that's a Richmond Behavioral Health Authority. I began working in crisis mental health with youth. I did that for 2.5 years. Then I began working with adults, also in a crisis setting. And currently I'm still working with adults. I'm still in crisis work and part of a regional community stabilization program housed at RBHA that assists with mobile crisis responses. So those mobile crisis responses are somewhat tied to the 988 program, which I'm sure you've seen all of the advertisements for. When someone calls 988 in the Richmond area or somewhere within the region that my program serves, it's possible that someone from my team would be pinged for a mobile crisis response. should the caller request a clinician to be on site with them. I truly believe in the work that we are doing as it supports hospital diversion when it's appropriate, as well as gives individuals in crisis the resource of a mental health worker rather than having to call 911 and potentially get a police officer instead. So in order to begin covering crisis work and SMI, I believe in reviewing history of crisis mental health work in Virginia. It helps to provide context to why certain programs and agendas are pushed, as well as gives us as providers important background information of the history that our clients and their families in the community might have experienced. So going all the way back, we of course think of institutionalization focused on restraining and controlling rather than any sort of treatment or therapy. Then we move into deinstitutionalization in the 1900s, placing emphasis on individuals returning back to their communities and those community supports, receiving treatment there. Then in 1968, Virginia General Assembly approved community service boards. So community service boards aim to be, according to the Virginia Department of Behavioral Health and Developmental Services, or DBHDS, quote, single points of entry to publicly funded mental health, end quote. So for the city of Richmond, Richmond Behavioral Health Authority is the community service board for the area. Other cities nearby have their own, such as Chesterfield Mental Health, Henrico Mental Health, Hanover CSB, and more. They all have varying names that sound pretty similar, but I like to list a couple of them off because they're not quite the same. So community service boards have allowed individuals to receive mental health services at no cost and quickly, as I'm sure we're all aware of wait lists, lack of insurance coverage that often prevents people from receiving the care that they need. So the next two events that I'm going to be highlighting on this timeline, I believe to be essential for understanding not only Virginia, but Richmond Crisis Services. They're both very serious and intense events. And while I'll just be briefly recapping those incidents, I do want to be mindful of how upsetting these events can be to hear. And I want to offer a trigger warning for discussion of violence, murder, police involvement, and specifically to that second event, harm to the African American community. So if you're familiar with these events and you prefer to not wish to hear them summarized, that's perfectly fine by me. I'll give y'all a thumbs up when I'm done with that section if you want to turn down your volume and turn it back up. So in 2013, State Senator Craig Deeds obtained an ECO, otherwise known as an emergency custody order, for his son. He was concerned about his son's mental health. His son had stopped taking medication that he was prescribed, and the family had noticed a change in behavior and sought out a higher level of care. So the mental health worker that evaluated Deed's son determined that inpatient admission was appropriate, so they were going to pursue hospitalization for him, but they were unable to find an available bed. This is a common occurrence that hospitals are crowded. People wait in emergency rooms for bed placement for long periods of time. And back then, ECOs expired after 6 hours. There have since been changes made. And ECOs now expire after 8 hours. So at the end of that 6-hour hold, they were still waiting for a bed placement for Senator Deed's son. And since he was being admitted involuntarily under the ECO rather than voluntarily seeking hospitalization, he was then discharged back home with a safety plan. And then the day after this hospitalization or attempted hospitalization occurred, Crady's son stabbed his father, the senator, multiple times before completing suicide. So Deed's had survived that incident and has since called for mental health reform in Virginia, and the bed of last resort has been put in place. So that mandates that state hospitals provide an available bed for anyone determined to be needing emergency inpatient treatment. So the order of events needed for hospital admission has also changed after this incident, so that TDOs or temporary detainment orders can be placed on an individual if they have been determined to need hospitalization and that bed search is taking longer than anticipated. And TDOs place a hold on someone for 72 hours. So then that next event in 2018 is when a local Richmond resident experienced a mental health crisis. His name is Marcus David Peters. During that crisis, he interacted with Richmond police, where he was tasered and ultimately shot and killed by officers. So Marcus David Peters' family and the Richmond community have also called for both police reform and mental health reform, rightfully so. And the Marcus Alert program was created after this tragedy, which is linked to the 988 crisis hotline. Under Marcus Alert, regional crisis centers assess and help determine intervention needed, which can range from over the phone de-escalation to the mobile crisis responses that I reviewed earlier, and also includes a co-response team, which involves mental health workers responding out to situations alongside police officers. I also think that it's important to note that the original proposal by Marcus David Peters' sister, Princess Blanding, for the Marcus Alert called for much more extensive reform than we're currently seeing. So some things have changed, but not as much as the community is desiring. Okay, this is my thumbs up for folks that might have muted. Finally, the last event that I have listed is the COVID-19 pandemic, as it's had such a huge impact on crisis services in Virginia. In the pandemic, we saw decreased staffing in so many areas of mental health, increased census in hospitals, and hospitals becoming so overwhelmed that they could no longer admit individuals needing care. High turnover rates in mental health worker positions have continued since 2020. Alrighty, I'm gonna get into some definitions. So the National Institute of Mental Health definition of psychosis refers to a collection of symptoms that affect the mind, where there's been some loss of contact with reality. During an episode of psychosis, a person's thoughts and perceptions are disrupted and they might have difficulty recognizing what's real and what's not. And then the second definition I have listed is coming from SAMHSA, which is the Substance Abuse and Mental Health Service Administration, talking about co-occurring disorders, which is the coexistence of both a mental health illness and a substance use disorder, or the coexistence of multiple mental health diagnoses can also be referred to as co-occurring disorders. And then finally, there's medication non-compliance. I prefer to use the term non-adherence, as I think it's a lot more person-centered. Adherence tends to be more proactive and positive, while compliance leans a little bit more towards following instructions passively. But that can be defined as when individuals are not taking their medication as prescribed. So medication non-adherence can be intentional or unintentional. It's important to examine the reasons why for medication non-adherence, as doing so dismisses clients' dignity and worth. By not examining the reasons that one may or may not take medications as prescribed, a provider could incorrectly assume that the client does not value their treatment, when in reality, there can be so many factors that contribute to non-adherence. So individuals may not notice a change in their symptoms after taking medication, which does not really promote continuing a usually costly routine, or just a routine in general that can be hard to establish. Cost of medications due to prescribers, health insurance, specific types of health insurance, medication shortages, and more. Mistrust is also a very important reason that clients may not adhere to medication instructions. The medical field has a long history of harming minority groups of folks, which very rightfully then leads generational mistrust of prescribers. Along those lines, if there's any confusion regarding instructions of medications due to providers' inability to adequately support the client while describing medication, or client misunderstanding, clients may not feel comfortable taking their medications without that full understanding. And then that leads well into concern regarding side effects. Typically, with most medications, there's a long list of potential side effects, which can be experienced to varying degrees. That list can be daunting, as individuals may have personal experience with those symptoms from previous medications, which could lead them to feel as though they're just better off not taking it at all. Symptoms fading is another common reason that many folks fall off of their medication routine and fall into non-adherence. Once symptoms lessen, individuals might feel as though they're no longer needing the medication, similar to the use of an antibiotic for an infection. However, adherence to medications is so crucial to maintaining those lack of symptoms. Additionally, concern regarding dependency can be a reason that one may not adhere to medication instructions. The common concern that I've seen in the work that I do, so often people want to start a medication because they feel as though they just need a little bit of help for now, but once their symptoms have subsided, they feel as though maybe they can handle it on their own. Persons with a history of addiction may also feel concerned engaging in regular medication use. It might feel overwhelming to think of the likelihood that someone might be on a medication for a very long time. That can be really overwhelming to think about and can feel as though nothing is ever going to be solved if you just have to be on this medication for the foreseeable future. So depressive symptoms can also, of course, contribute to medication non-adherence. When someone's feeling depressed, self-care habits, including medication use, can be deprioritized. And then lastly on this slide, but certainly not the final reason our clients may not adhere to medication prescription, is an inability to hold appointment times. That could result in lack of refills on prescriptions, and so many things can contribute to that, including transportation to appointments, work scheduling, and other life responsibilities. As I know that is not a complete list of why folks may not be medication adherent, I want to open it to y'all at this point. Is there anything that you feel like hasn't been covered here that you've either witnessed or know regarding major reasons that our clients may not adhere to medication instructions?
I'm sorry, I got here a little late, but I did want to say something about sometimes the medications make them feel like a robot, or like, since it's like they don't feel like they're feeling anything, especially individuals, not especially, but like individuals with bipolar, when they don't have those manic episodes. I have family members like that who say, this doesn't work for me.
Yeah, definitely. Yeah, that numbness is just really unpleasant and really foreign. For sure. Thank you.
I would say, especially with younger adults who maybe are experiencing, first episode, denial,
Mm.
And then also, this is a time when young adults want to be with their friends and go to college and do do other things that young adults do. And having to reconcile that this is a disorder that may require long-term medication is particularly difficult. So wanting to just be normal, like everybody else, like my friends.
Yeah, but those built-in routines and like appointments and things that need to be followed can just feel burdensome.
And if I may add, just the stigma surrounding, having to take meds for your mental health and, the societal attitudes towards that can be a lot as well.
Right, yeah, because are you gonna talk about the fact that you have to now take this medication maybe at a certain time of the day while you're around people? Or are you going to hide it, and how does that affect you?
I would also like to add, it may be a control aspect where it's, especially for kids in foster care, a lot of things that they can't control in their environment, but refusing their medication is something they can.
Oh yeah, definitely, yeah, if it just feels like another thing that the adults around you are telling you you have to do, it doesn't feel like a choice or something that you're doing truly for yourself.
And I'm sorry, Emma, Cassie, I don't know if you're looking at the chat, or Emma, if you can see. There's a question there. You want me to read it out? What did we
Sure,
decide?
that'd be great.
Yeah. And then Dana has her hand up. So the comment from Mariah is, I feel like it's well known that some people struggle with consistency of
Mm.
taking meds and showing up to appointments. So why do so many practices have a policy of discontinuing services with later missed appointments?
Ooh. Yeah, I know that I can only speak to that in terms of the free mental health work that I have provided. As I'm sure private practices and things like that have to adhere to different rules. I know that for us specifically, services end and we have to remove someone from a caseload because if we say that we're providing a service to people and we aren't seeing them regularly, we can still be asked should something bad happen, which is like the unfortunate part of why rules are in place, is protecting groups of people. But should something happen to someone and they say, okay, well, they were in services with you, then you have to say, we actually haven't been seeing each other for the past couple of months. I can't speak to their well-being. Then it's not appropriate for me to say that I'm providing any services to someone. But of course, that's from my work that I've done rather than any sort of private practice work.
And Emma, like Gary had said, Dana's hand has been raised for a while.
Okay.
Oh, just wanted to comment on medication non-adherence. One possibility could be individuals who are trying to conceive or are pregnant may be concerned about taking the medications. Not that they themselves have had bad side effects or have cost issues, but they're concerned about the pregnancy.
Yeah. Oh, that's a huge one. Yeah, definitely. And then folks that might be breastfeeding, additionally, having to factor that into what sorts of medications they can be taking at what point. But that's not that pregnancy is short, pregnancy is so long. But that's a very long span of time that you can have to consider what you're taking.
I'd like to add on to that. There's also just such limited research when you are pregnant that when you're asking doctors like what medications you can or cannot take while pregnant, due to the limited research on whether it can affect your baby in utero, I think that also kind of makes it more difficult for an individual who's pregnant or trying to conceive about taking medications. Doctors are just so unsure that I feel makes it hard to either stay on the medication or not. And pregnant,
Right.
and that's a long 9 months. You're
It
dealing
is.
with hormones, if you have a mental health diagnosis on top of that, that's a lot to deal with for nine months.
For sure. Yeah, and then any sort of mistrust that you might have coming from that would definitely be impacting it as well. Thanks so much for everybody's responses. I love learning more. Is there anyone else before I flip to our next slide? So something I want to touch on is psychosis and crisis work. I know that previous speakers have spoken about psychosis. So I think it's important to note that psychosis itself is not just a diagnosis, as many mental health diagnoses experience psychosis. So the Cleveland Clinic describes psychosis as a collection of symptoms, where someone has a hard time distinguishing between what's real and what's not. So two of the most common types of psychosis that we're seeing in the work that I do in crisis work is hallucinations and delusions. Hallucinations are, of course, when your brain is acting as though your senses have registered something that is not actually there. So that could be auditory, visual, tactile, gustatory, which is taste, or olfactory, which is smell. And then delusions are that belief that something is true regardless of evidence contrary. So common delusions that we're seeing in crisis work are extreme paranoia, grandiose delusions such as believing oneself to be a celebrity or possessing special powers, or what is referred to as a bizarre delusion, which essentially means that the delusion is out of the realm of what anyone could be experiencing, regardless of that diagnosis or state, such as someone believing that aliens have taken over the body of someone that they really trust. So a request of the presentation was to highlight what diagnoses containing psychosis crisis workers are currently interacting with. Although I can't speak to all crisis workers, the work that myself and my team does regularly interacts with folks experiencing psychosis or with a history of psychosis. And the most common diagnoses that we're interacting with are schizophrenia, schizoaffective disorder, bipolar disorder with psychotic features, and then MDD with psychotic features. Okay. So I wanted to do a bit of a case review. So all PHI has, of course, been removed from the case description. I have a couple of these throughout the presentation, hopefully to provide some real world examples of the things that crisis workers are currently interacting with. So this case highlights a fairly standard interaction between the hospital system for individuals experiencing psychosis. What makes this case unique is, in my opinion, how young the client is. So psychosis can, of course, appear in late adolescence and young adulthood, but the typical crisis caseload that myself and my coworkers were carrying at the time of this had so much higher prevalence of suicidal ideation compared to psychosis. So this was a little out of the norm. So we received a referral for community stabilization services from the client's family for increased mental health concerns, specifically regarding anger and elopement. So at that time, no psychosis mentioned in the referral. So in completing an intake, we verified those concerns, which is not always typical when interacting with youth. You know, their family reports one thing, they're experiencing something else. But that individual stated that he had been really, really struggling since the loss of his father and felt like no one at home understood him. His father was the person that he was going to for so much of that support. And then when reviewing safety concerns and developing a safety plan, as is typical for all interactions with crisis work, the individual denied suicidal ideation and endorsed some passive thoughts of self-harm, not abnormal for the work that we're doing. and denied any sort of plan or intent. So that meant that we could safety plan for being at home. So he also denied a history of any sort of plans or attempts to hurt himself or others. And at the time, he denied any sort of audiovisual hallucinations. So then a few days later, when we were completing our first community stabilization session post-discharge, where we're typically discussing treatment planning, goals for the work together. During that conversation, he disclosed some audio hallucinations. He denied any sort of command hallucinations, which is always something important to be asking about, as that's pretty distinct. He also denied finding the hallucinations to be distressing at all. He referred to them as his spirit guides. And I found no reason at that time as a clinician to break HIPAA, because there were no signs of imminent harm to himself or others. And we want to be really careful about when we are breaking HIPAA, as that can be a huge breach of trust for folks. But as there was no plan or intent at that time, we decided safety planning was still appropriate and remaining home was still appropriate. So day after that session, as it always seems to go within crisis work, things are fine, and then they are not. I received a call from RBHA's emergency services, which are the folks that when you go to the hospital, the emergency services department in that area is providing an assessment to determine whether that person needs to be hospitalized. So RBHA emergency services contacted me stating that my client had taken public transportation in the middle of the night from his home to Richmond City, directly to a hospital, which, you know, better than elsewhere. He did so without alerting his family. He was seeking admission, and emergency services had the individual under an ECO at that time and was contacting some collateral sources to inform their decision. He ended up being admitted and planned to discharge back into the community for the community stabilization services that we had begun, with a plan to link to long-term services, as the services that I was providing were short-term. After he was discharged, he came back onto my caseload, and we worked with the hospital and the family to set the family up with intensive in-home services. Intensive in-home services, for those not familiar, are weary workers coming to someone's home a couple times a week for a couple hours at a time. It's intensive, like in the name, working on some of those life skills along with mental health services. It's known as higher level of care than your average outpatient therapist, but not as high level or restrictive as the hospital would be for folks. So we continue to meet twice weekly because acuity was so high due to him just discharging from the hospital, until those intensive in-home services began. We consider intensive in-home to be a higher level of care than the program that I was working for at the time. So we ended up discharging once he was linked, and then also made sure that he was linked with psychiatry services. And then he had already started on some medication once he was hospitalized, which he wasn't previously on. So I found this case so interesting for a couple of reasons. Psychosis at a young age is not extremely common. In this situation, you can see could have gone very wrong in the manner in which the individual arrived to the hospital, but communication between the family, providers, and referrals to that long-term care ended up working really well for the individual and was able to mitigate some of those safety risks that we were worried about. It was obvious that the individual was feeling more comfortable during that second session when compared to the first, as when he began services denying any sort of audiovisual hallucinations, then ended up endorsing them, and then shortly after seeking immediate care. There can be so much shame and worry associated with mental health concerns, like we talked about with that medication non-adherence piece. And that individual and I spoke at length about that worry and judgment from their family and their community for the rest of our services together. Okay. Moving into engaging individuals and experiencing psychosis, figured it would be helpful to put in a couple of tips. So clients' right to self-determination is key when engaging with someone experiencing psychosis or with a history of psychosis. In crisis work, it's important to remember that we're meeting folks, some of them on one of their hardest days. And safety and support are the most important things to establish. In order to do that, specifically with folks experiencing psychosis, meeting the client where they are is key. That involves listening to their concerns and collaborating on treatment options. And when folks are experiencing psychosis, it's important to not challenge those beliefs, as their experiences are so real to them. You can, of course, attempt any sort of grounding exercises if that would decrease anxiety or panic for them. But challenging any sort of delusions or hallucinations can just be really invalidating, and it's not like it's really going to change their reality. And then finally, many people who experience psychosis live within a community and don't need to be referred to the hospital. If you're interacting with someone for the first time and they have the ability to consult with any other collaborative sources, or when you have the ability rather to consult with any other collaborative sources, it's important to review any changes in routines and assess for ability to care for oneself. Because if someone's not able to maintain orientation and possesses a significant risk of harming themselves or others, a higher level of care may be explored, but it shouldn't be the automatic. Hospitalization can be so traumatizing, both the process and the experience once hospitalized, that psychosis doesn't guarantee that someone should automatically be admitted. So I wanted to talk a bit about protective factors. Also included in this, of course, would be risk factors, which would be the inverse, but I prefer to focus more on the protective. Okay. So in interacting with someone in a crisis setting, things that we're often asking are questions about and considering risk and protective factors are stable housing. We'll get into this a little bit more in a bit, but housing instability most certainly exacerbates mental health concerns and affects so many parts of someone's life. Income stability, whether from a job, SSDI or SSI, or money from other sources. Future orientation, someone's thinking about the future in any sort of capacity, something that they're looking forward to, something that they want to accomplish, a trip that they're excited about, or someone important to them that they'll see soon, are all such great signs that someone has the motivation to live, to receive support, and engage with mental health resources. Social supports are also huge. Truly one of the most important. Community is everything, and whether that's family, friends, religion, culture, romantic relationships, animals. I've had so many clients that their safety plan is truly that they are wanting to live for their animals and their animals alone, and that's enough for them. Also coworkers, if someone just feels connected to their community, there is such a higher chance that they'll engage in services and feel supported while doing so. Additionally, personal goals, any sort of motivation to begin services, or even acknowledgement that what they have done in the past to cope is no longer working for them and a higher level of care is needed, shows such insight and is such a protective factor for services. Insight while in crisis is so important and can be so rare. Finally, access to transportation is huge. Since the pandemic, many services offer virtual options. But considering folks' access to platforms that have those virtual options, transportation can still be so important if someone doesn't have a phone with a video feature or a laptop or any sort of device like that. When discussing immediate treatment or continued care for a crisis, transportation is always a conversation that we're having with folks. Lack of transportation can be such a barrier to mental health services, but also employment, food resources, accessing their community, and overall well-being. So similar to when I was discussing medication non-adherence, are there any protective factors that y'all feel like were missed that would be important to note in working with individuals in crisis? Go ahead.
I think it's, oh, sorry.
Oh, sorry.
No, and then after that, you have a hand raised, Emma, too.
Great.
I think it's kind of related to social supports, but I think also connecting like a client's connection to resources too, like different organizations or agencies. So not just like the social aspect, but like other resources that they're getting assistance from.
Yeah, definitely. And sometimes that means a combination of a couple of resources, that there isn't just one worker from one program that they are connected to, so that if they're needing things at different times, they can feel supported, for sure. I see a hand from Jessica. Go ahead.
Hi. While you were reviewing these concepts, something that came to mind was when you talk about social supports, so many of these disorders have like, or not illnesses, I apologize. Like the characteristics involve almost like chasing away the people that do support them. And so these sort of protective factors can change so quickly. Yeah, I just, it's very complicated because one moment you have like someone who's in your corner, and then if they don't know how to help you, sometimes that can lead to like them falling apart.
Yeah, definitely. So like quality of those social supports, knowing that you need people that are looking out for your well-being all the time rather than just interacting with you when things are feeling good.
Emma, in the chat, you have someone that's communicated that channels for creative expression could be a protective factor, as well as insight into illness and ability and willingness to voice need.
Nice. Yeah. Yeah. So any sort of activity that you can be engaged in that's bringing you some sort of purpose and meaning. And then insight for sure. Yeah. If you are able to better understand what you are experiencing and can sort of separate that from who you believe you are in your core, rather than just the symptoms that you're experiencing, can be so important.
And the last thing to unmute, someone is also tied in their cultural connection as well as a protective factor.
Yeah. Yeah. Awesome. Well, thank you. Alrighty. So looking at co-occurring disorders, that statistic is according to Caring.org, which is that 1 in 4 individuals with SMI has a co-occurring experience with SUD. So reasons for that could include genetics, as some genes put individuals more at risk for addiction, and genes cause people to respond differently to substances. Additionally, mental health diagnoses can cause someone to engage in substance misuse, as substances can be used to cope with symptoms at first and then could lead to dependency and subsequently an SUD diagnosis. It's important to also acknowledge the environmental factors that contribute to both SMI and SUD. So individuals who've experienced trauma and chronic stress can have noticeable changes in their brain. Those folks could perceive situations differently due to that trauma and therefore choose different coping skills to deal with their stress. Alrighty, we have another case review. This time I'm talking about a mobile crisis response. So in my current role, part of my responsibility is working on my program's crisis hotline. As I mentioned a bit earlier, the hotline is one of the local resources that Nationwide 988 utilizes to connect folks in need with crisis mental health workers. So I work on that crisis hotline as part of a rotating on-call shift. I wanted to talk about what a call for an adult with schizophrenia diagnosis might look like based on a call that I took recently. So a bit of background, we received a call from the mother of an individual currently receiving services through their local community services board. Those services that he was receiving were ACT services, which stands for Assertive Community Treatment. And it's considered to be one of the highest frequency community mental health programs. Folks that are enrolled in ACT services are seeing their clinicians multiple times a week for extended periods of time, as the program states that it works with those, this is quoting ACT, with severe and persistent mental illness, end quote. So this individual was diagnosed with schizophrenia and receiving treatment through their CSB, which included some medication management. That individual's mother contacted us as she was feeling overwhelmed, stated she didn't know what to do. It appeared as though her and her son were having a conflict and both were receptive to speaking with clinicians. So they requested for this to be in person, as are the majority of our mobile crisis responses. So myself and a new staff member who I happened to be training, dispatched to the family's home. Typically I would be doing that by myself, but it was pretty great to have somebody alongside me so that we could divide and conquer when needed. So when we arrived, we introduced ourselves, talked about what mobile crisis responses entail, and that's just as a way to provide some education on our services, as well as informally set some expectations about what we were there to provide, because it can be so frustrating if folks feel as though you are there to provide them with something that you can't, or at the end of an hour or two's worth of work, they feel as though their needs are still not met because they were expecting something else. So we spoke with mom and the son separately, which is a method that I often use when dealing with escalated folks who typically only further escalate each other by continued interaction, which is pretty common within family dynamics, both with younger folks as well as this person who was a little bit older. So my coworker and I spoke with the son first, wanting to work on rapport building, since we spoke to him only so briefly on the phone and his mom was the one that was calling. Once we were able to establish that there weren't any safety concerns and process through his current stressors and coping skills, we then spoke with his mom, the original caller. She stated that an incident the night before had led to some further conflict today, and she was feeling overwhelmed by the many appointments that she had to provide transportation to for her son. So we asked for the contact information for the ACT program that works with the family. And we were able to coordinate with them and confirm the next appointment times, making sure everybody's on the same page to continue the services that they were seeking. And then the ACT team ended up having some resources to assist with transportation issues, which was a huge help to the family and us, as that made our job significantly easier, since we were there to de-escalate. We ended up wrapping up our mobile crisis response by bringing the mother and the son together and reviewing the plan for the evening with an emphasis on engaging in some coping skills that we had discussed individually with each person. For the mom, that happened to be spending some time outside in her garden, and for her son, it involved smoking on the front porch and some time alone in his room. We talked about upcoming appointments that would be supportive to the family, knowing that thinking about future supports would also ease some anxieties. And then we also reviewed some natural supports like friends and family, as well as some formal supports like our crisis hotline should something escalate and they need some support in the future. I'd like to say that this wasn't a typical MCR, but the reality of crisis work is that it is rarely predictable. To this family, an opportunity to be heard and validated and supported seemed to be really significant. And I think that's such an important and sometimes overlooked part of providing mental health services. Someone that I think about often is Nicole Arts. She's an LMFT that I really enjoy. She creates a lot of content online, but also has a book. She talks a lot about what it means to be a therapist, but also what it means to be a mental health provider, and has said, which I'm not quoting her directly, I tried to search for the quote. It was at one point in time, the background on my work phone when I first began my job and I was needing some consistent motivation. But she has said that in the times that you're feeling stuck clinically, it's important to reflect on the space that you're creating for a client. So many people do not have someone in their life that can actively listen without responding in a way that centers themselves or their personal beliefs. And we get to provide that for clients, and that itself can be transformative. Going to shift into physical illness and SMI. So it's vital when possible to discuss any physical diagnoses when interacting with a new individual, as it can provide context for symptoms that they're experiencing. Obviously, we shouldn't be making any medical recommendations outside of advising an individual to seek medical assistance or consult, but background knowledge of these diagnoses and their presentation can better inform a clinician's interaction. So autoimmune disorders like lupus and MS can affect one's mental health and cause psychosis. Severe cases of lupus can cause stroke, psychosis, seizures, memory loss, and that can consist of audio and visual hallucinations, confusion, paranoia, and could subside quickly, reportedly within a few hours or a few days. MS patients can experience hallucinations and delusions as well, which can be caused by medications that they're prescribed to treat their condition. So that can be altered by changing the medication and beginning the individual on an antipsychotic medication. Additionally, secondary mania, as it's referred to by psychologists, can occur at any age to individuals who do not have any sort of history of a mood disorder. Psychologists often associate that with more often with brain disease, which HIV and AIDS can cause. Symptoms that are often seen are audiovisual hallucinations and paranoia. An occurrence of that has decreased with more folks with HIV and AIDS utilizing ART or antiretroviral therapy, or a series of medications for HIV and AIDS treatment. PANDAS is something that actually came up for a coworker of mine, which I found to be super interesting, often occurring within children under 13 who develop or have an increase in an OCD or tic disorder after being infected with strep throat, specifically group A strep. So it's not infectious and it occurs within 20 to 48 hours of the onset of strep. And treatment is just antibiotics as there's no vaccine available. Sepsis, when one's body has a severe reaction to bacteria. It's common in infants and older adults, and it can be found after surgical procedures and can result in feelings of confusion or delusions. That you can see so often within elderly clients that might be experiencing that infection following a surgical procedure, and hospitalization is just what's needed to treat that. Electrolyte and mineral metabolism disorders can be caused by a variety of factors, including genetics, hydration complications, hormonal or endocrine disorders, alcoholism, and more. Symptoms of that can include confusion and dizziness, which present similarly to SMI if no one or if someone's not able to orient themselves. And heart attacks and stroke can also cause an individual to experience confusion, difficulty understanding speech or speaking themselves. So just like we discussed with crisis services in Virginia, in order to examine housing insecurity and mental health, I believe it's important to first discuss housing concerns in our own community here in Richmond. So the statistic that is on the screen there is according to an article published by VCU. So in 2020 and 2022, the federal rent relief funding caused evictions to decrease by 350% in RVA. With Richmond losing subsidized and affordable housing beginning in 2000 and continuing year after year, unless a dramatic change happens. And then in 2022, pandemic eviction protections expired. In April of 2023, affordable housing funding was put in place, or rather Richmond City declared a housing crisis due to the increased eviction rates. And then in October of 2023, it was announced that a national organization, LISC, will be contributing $50 million in $10 million increments over the next 5 years in Richmond to create at least 1,000 new housing units a year. So there is hope. And also, as someone who has been part of the system and witnessed the system, I still have my concerns. So talking about housing insecurity and mental health, something that I'm sure we're all familiar with is Maslow's hierarchy of needs. I refer to this so often in the work that I'm doing within crisis work, as typically the major concerns at the time are those physiological or safety and security needs. So the physiological needs highlighted by Maslow's hierarchy are food, water, shelter, clothing, and sleep. And if an individual is unable to maintain shelter, it's likely that sleep will also be affected. If stable housing is a concern due to financial need, it's also likely that food and water can be a need as well. It's so difficult to expect any human to be able to attend work regularly, attend appointments, and have time and energy to work towards big picture goals if their immediate future is unknown. And for this reason, housing instability can, of course, lead to and enhance already existing symptoms of a mental health diagnosis. My last case review is related to housing and SMI. So speaking to another client that I interacted with while providing crisis mental health services specific to housing, a 30-year-old female called the crisis hotline asking for mental health support among some other needs. The individual had recently relocated to Richmond with her partner and her 5 children and was unaware of resources in the area. So she needed assistance enrolling the kids in school, transportation to school, securing long-term housing as they were currently staying in a single hotel room, her partner, and 5 children. and mental health supports as she was attempting to move forward with her life in Richmond while processing through the extreme trauma that she had experienced in her previous city, which was what had caused her to finally leave the city and her family that was there as well. So we first addressed any sort of safety concerns, like I've talked about before. Safety is such an inherent part of crisis work. She was able to contract for safety and had no immediate concerns that would warrant a visit to the hospital for further screening. We talked about coping skills. Typically in crisis moments, the work that I do is really strengths-based, reflecting on how people have persevered through hard moments in the past. Discussing supports that can get them there in the future and making sure that they're aware of the supports that they may not be utilizing right now. For this client, that included some brief orientation to Richmond services, so she was new to the area. Together, we reviewed local resources. I provided her with a follow-up email and text listing out all of those resources that we discussed, which included numbers, links, etc. During a crisis moment, I'm never too focused on that big picture. So the situation was unique in the sense that she was feeling overwhelmed by all of the big picture resources that she was needing, while also experiencing such overwhelming anxiety that we ended up discussing both. As I noted before, I ended up working with this family for a bit, doing some community stabilization services. And each week we checked in about safety concerns, any changes to ADLs, helping them get linked to case management services through their CSB, as well as linking the mom, our primary client, to an outpatient therapist and referring to McKinney-Vento, which is the local program that assists families who might be houseless and in a transitionary period of their lives with resources related to school, transportation to school, etc. So before we wrap up, I wanted to cover crisis mental health resources in Richmond. The first one being hotlines like the Region 4 Mobile Crisis Hotline, which happens to be the hotline that I've been referring to throughout this presentation of where my work operates from, but is the regional crisis hotline, or 988, as they both support each other. Services like a mobile crisis response can be accessed through that Region 4 Mobile Crisis Hotline or through 988. So in calling into the crisis hotline, one could talk to someone, a clinician on the phone for a bit, or they could receive a mobile crisis response. A crisis stabilization unit, which is located at Richmond Behavioral Health Authority and acts as a place that is a voluntary treatment for any sort of mental health concern. That individuals typically stay at for 5 to 7 days, and it's considered to be a lower level of care than the hospital and a more tailored experience to an individual as the unit is small. Folks are engaging in several groups throughout the day. There's round-the-clock nurses so that if folks are wanting to get started on any sort of medication, they can do that, or change their medication if what they are currently taking isn't working for them. We also have North Campus, which is through our BHA, that's specifically substance related and provides some inpatient options there. And then anyone's community service board. So those are what I listed earlier as far as Richmond Behavioral Health Authority, Henrico Mental Health, Hanover CSB, Chesterfield Mental Health. I think that this listing of crisis mental health resources can be so important for clients that you have currently, clients you might see in the future, or people within your community, as I'm sure you've experienced that folks in your life might call you for some mental health resources, and it can be so helpful to know what options are out there rather than just having to call 988 although you can now do so, and you won't be connected automatically with a dispatcher for a police officer. So that wraps up my presentation for today. I just have some sources listed as I cited so many things and did a bit of research. I would
Emma,
love
you
to-
do have some questions in the chat, if I can tell you them. if
Yeah,
that's
that'd be
okay.
great.
So the 3 questions that are here are, if you have any information that you can expand on pandas, if we could start there, if you do.
Sadly, I don't. I didn't experience that directly, nor was I that person's coworker at the time that it occurred. But it was just a conversation I had had with my coworker about an individual that she had been seeing that was experiencing those heightened tick behaviors. And then once they had discussed with the family some quick medical history, found out that they had recently contracted strep. That person was being seen during the pandemic, so all services were virtual, which I like to think maybe could have helped in a diagnosis, as we probably wouldn't be attending the family's home and seeing that person quite regularly. But that's the extent of my knowledge, unfortunately.
No, that's okay. And I did put information from the National Institute of Mental Health about pandas here in the chat, and I'll just share it one more time for anyone who's interested in learning a little bit more. So another question that you received was basically do you know any information or anything about if there's going to be more? The question is phrased as, is there any hope that there will be community stabilization or skill building for Medicare?
Oh, for Medicare, interesting. I don't know the answer to that, as most of the folks that we're seeing have Medicaid. And I have been super fortunate in the fact that the program that I am a part of is state funded. So if you were, okay, so maybe this is my answer. If the person that you were wanting to refer is located within Region 4 and they're looking for community stabilization services and they have Medicare, CREST, the organization that I'm part of, which you can access through our VHA or any sort of community service board in Region 4, is state funded. So our services are free.
That's a good
Super
answer.
simple.
The other question in the chat, and then after that, for all the participants, please unmute and ask your questions, is do you know of any, you shared a great list of resources. Do you know of any crisis resources that are available statewide that are not exclusive to Richmond that you could possibly share? And if you don't know them now and can share them later, then I can share them out to the attendees.
Sure. So 988 would be statewide as it is nationwide. And typically they would be referring to their local region or wherever the caller is coming from. When I was discussing, let me go back a slide. When I was discussing the crisis stabilization unit and North Campus and mobile crisis responses through Region 4 mobile crisis hotline, those are all regional. So if you happen to know someone that is located in Farmville, we go all the way out there. They could access any of those services that I just described, all the way down to Emporia we cover, Region 4 covers, so it's a pretty good chunk of the state. Otherwise, what I'm typically doing is referring folks, if we were to get a rogue call from someone in Vienna, and they are looking for services similar to ours, I typically refer them to their community service boards, emergency services line, as they tend to be the experts in local resources.
That's a great answer. And now for any other participants that are here, we have, about 15 minutes. Does anyone have any questions that you would like to ask?
I have a question or comment. My name is Lauren.
Hi.
Can you hear me okay? Hi. In your first case, did you say that the child had lost his father? His father had
Yeah.
passed? Okay. I'm just curious. I got my MSW when it was biopsychosocial back in '93, and I knew it's now biopsychosocial spiritual. And I'm wondering, in the crisis work with seriously mental illness, what gains have been made in determining the difference between a spiritual awakening experience? When you mentioned spirit guides, I wonder about that versus a psychotic experience. They're doing a lot of work out of UVA and the Division of Perceptual Studies with extrasensory perception. We've come so far in the last 30 years with intuitive, with if you accept the premise that a soul, exists separate from the body. So I'm just sort of wanting to get an update on that, and was any kind of any questions about that with this particular child, given that you said that it is rare, and I don't do your type of work, so I'm just not sure. I'm just curious about all of this.
Yeah, definitely. Well, I
Question.
think also, no, that's a good question. I think that it's so interesting when working with you specifically, who seem to be so much less tied to adult ideas of like what's real and what's not. There's so much more freedom of expression when you're younger that I think that can lend itself to that spirituality that maybe folks that are a little bit older have a harder time accessing. As far as like what crisis protocols or common practices there are, I don't feel like there have been, at least in the work that I do, too much focus on exploring the spiritual portion of that, as it tends to be so unique to the individual. And so many people either have spiritual beliefs, but might not be experiencing psychosis. And it tends to be just so clinician based as far as what questions you're asking and what you are assessing for. The threshold that we're usually looking for is whether someone can maintain their safety, and that's what we're usually so focused on. But I do find that to be so interesting.
Thanks, Lauren. Anyone else? Anyone else have any thoughts or questions that they'd like to ask Emma?
Hi, my name is Dee. Can you hear me?
I can, yes.
Okay, I think it might be a little dark where I'm sitting, so I apologize about that. But when you're doing the home visits, what did you have to do to like prepare yourself for that mentally? And what has helped you along the way as far as growing confidence and being able to do that in a person's home?
Yeah, that's such a good question. Because I think that I reflect on that so infrequently now that I've been doing it for so long. But I'll say at the very beginning, I was very nervous, very concerned. It feels very personal to be going into someone's home. I never want to come across as too formal, as people are typically meeting me in their casual clothes with their homes in various states. That practically what I do is we have permission to dress pretty casually, which is helpful. I will usually have like a mask on me should someone be ill or we experience like any sort of smells that are unpleasant or could be distracting. As far as preparation goes, safety wise, there's always someone that I can contact that knows where I am at all times, as we have our calendars shared. And if a referral comes in that looks particularly dicey or potentially dicey, I'll usually let folks know where I'm headed. Folks being my coworkers, of course, not anyone else in my life. And I think getting past like any sort of nerves, which happen pretty quick for me because you get used to it. I just find being able to be invited into someone's home to be such a privilege, that someone is at such a hard state in their life and they are still willing to accept someone brand new into their house, that so much of what I am doing is observing and just trying to be as present as possible.
Well, that was so, I really appreciate that advice and your thoughts about your experiences. So thank you.
Thanks for asking.
I have a question.
Mm-hmm.
You can hear me okay?
Yeah.
And I apologize for being off camera. I'm just in transit. I know I can draw from my personal experience with, you know, community, working with the community, and also with, you know, personal experience with my own family. I know that based on that experience, I've been really lucky in the sense that I have been through, I have been in a position where I've had to petition for ECOs and TDOs, and I've been very lucky because one, I just had like some baseline knowledge of, you know, what the magistrate was looking for, but I also had some help at one point. I actually have an experience where I actually turned in, you know, my written appeal, and the woman or the magistrate said, you know, I technically can't do anything with this. Here's what I need to see. And so I'm wondering, I'm just curious, really, in your work, how often do you come across families or individuals who have been unsuccessful with the ECO or TDO process?
Yeah. Oh, because it's such a huge barrier.
And it's, yeah.
Go ahead.
Yeah, no, I was just gonna say, in some ways it seems subjective. I know there is like very objective criteria, but you know, when you're that person whose loved one is in danger, it almost feels like you're at the mercy of this stranger who's making a call about, you know, the situation that you're the expert on.
Right. Right. Yeah, and I think that in some ways, of course, the strictness of those rules for applying for an ECO are so important that if we're talking about someone's rights being removed from them, it really should be a situation that is so incredibly serious. But on the other hand,
Yeah,
folks
absolutely.
folks that their families might not be super familiar with the system, or might not have the ability to patiently petition the magistrate as it's a process. Yeah, I've heard of families that have unsuccessfully petitioned the magistrate in terms of like they didn't get the outcome that they were hoping for. I think it is frustrating that currently the only folks offering paperless ECOs, as in not having to come forward with this documentation to get approval, are police officers. Because it really puts folks in a position where unless they are able to physically present in front of a magistrate and offer up all of this information, they're looking to call police to their home, which puts so many folks in danger of some other potential outcomes. And then you could also, you know, call the police to your home and go through that trauma, and then the police could say, no thanks, or rather, I don't think that this person meets criteria, because when someone's under an ECO by police officers, they have to then sit with them for those 8 hours before they are potentially TDO'd. And typically that's not something that anyone wants to do, is give up 8 hours of their time. So that's also a barrier to accessing that.
Yeah. Okay. Well, thank you. I just,
Yeah.
and all that is so true, you know, and I think,
Mhm.
and, you know, even in my situation, I can think of, you know, I would not have been able to go, to the magistrate had I not had, you know, support. And so often people, you know, like other bodies,
Right.
and so often, yeah, that's just not the case.
Right. Right.
So anyway, I was really just curious.
Yeah.
Thank you.
Thanks for your question.
One thing, if I can just say it, there are so many issues. Emma is highlighting them about ECOs, which are emergency custody orders, and TDOs in Virginia, which are temporary detention orders. We could have a whole speaker speak about them for sure. So I'm glad that Emma highlighted that. If these are things that you are not familiar with, please, you know, message me and I can send you some information so that you can familiarize yourselves with these topics, because again, that could be an entire speaker series on its own. So please don't hesitate to send a private message and I can send you some information if these are just terms or things that are unfamiliar to you, because we want to make sure that we're giving you as much information as we can.
Yeah, a huge part of the orientation process into crisis mental health work is learning about all of this, at least in the orientation I received, because it is so foreign to so many folks, unless you have very personal experience, in which case, who knows if you end up going to crisis work because maybe you were traumatized by it.
Yes. Or like me, watch TDOs happen and was like, this is very traumatizing.
Yeah.
Yeah, and if but we do have time for one more question or one more comment. So does anyone else have a question or a comment that they would like to bring to Emma before we wrap this up? Okay. Well, we want to thank Emma so much. Emma, thank you so much for your time, your expertise, and this really amazing presentation. I can say that I really enjoyed the cases that you presented. I think because I'm a social worker and I love hearing about cases, so I really am very grateful for that. Thank you all for attending today. Thank you all for being in the space with us. And have a good evening, everyone. Thank you all for being here.